Good afternoon, everyone. Thank you for attending our spring webinar collaboration between the Education and Training and Ambulatory Care PRNs. My name is Takova Wallace-Gay, and I'll be serving as your moderator for this afternoon's webinar session. As one housekeeping item, if you all have any questions throughout the session, please feel free to put them in the Q&A box, and we will field those towards the end of our presentation. And then also these slides, as well as a copy of the recording, will be distributed and posted following the webinar session today. So we have 4 speakers that will be sharing some information with us this afternoon. They've been doing some great work in the areas of interprofessional education and interprofessional precepting. And we'll start off with some core concepts and an introduction to interprofessional precepting from Drs. Ageniga and Westling, followed by some valuable information on navigating challenges and lessons learned from Dr. Dang. And then we'll wrap up with a practice model example from Dr. Crow. So to start, Dr. Ashlyn Ageniga is an assistant professor at HSC College of Pharmacy and a board certified ambulatory care pharmacist at HSC Health Family Medicine Clinic in Fort Worth, Texas. HSC Health's affiliation with a health science center comprised of 5 professional programs allows for a very robust interprofessional experience. Dr. Ageniga thoroughly enjoys precepting learners from multiple health professions to deliver optimal patient care. She'll be presenting this afternoon with Dr. Megan Westling, who is also an assistant professor at HSC College of Pharmacy and director of ambulatory care at HSC Health in Fort Worth, Texas. She is a board certified ambulatory care pharmacist serving patients at the HSC Health Family Medicine Clinic alongside Dr. Ageniga. The clinical pharmacists participate in an integrated interprofessional practice among other licensed healthcare professionals, residents, and students. Dr. Westling enjoys the interprofessional precepting role and opportunity to leverage interprofessional teamwork to achieve quality care to the medically complex patient population she serves. So at this time, I will turn it over to Drs. Ageniga and Westling for their section entitled Teamwork Makes the Dream Work, Interprofessional Precepting in the Ambulatory Care Setting.
Thank you for that kind introduction, Dr. Wallace-Gay. So I'll go ahead and jump right into our session. You can see the title there that Dr. Wallace-Gay went over with us. If you could go to the next slide. So the learning objective for the first part of this session is to describe strategies for successful precepting of interprofessional learners. So we'll kind of lay the groundwork and go over some key principles in implementing or starting your interprofessional precepting. Next slide. So Schrader and Zodke did the work for us in defining what interprofessional precepting is, and I wanted to go over that definition with you all. So interprofessional precepting is defined as intentionally educating learners from multiple professions in authentic practice-based settings, combining clinical teaching and patient care with explicit conversations about how interprofessional collaboration contributes to high-quality, patient-centered, team-based care. And so the 2 components here I want to focus on is the authentic practice-based settings, and then we're also mixing the clinical teaching and patient care component with how do students participate in interprofessional collaboration. Next slide. So to give some background on why do we care about interprofessional precepting, why do we need to provide interprofessional education and practice? So to start with, interprofessional collaboration contributes to the quadruple aim in healthcare. For those who are unfamiliar, the quadruple aims have to do with reducing costs of healthcare, improving population health, patient outcomes and experience, as well as the team, healthcare team well-being in general. And so there are studies that show that interprofessional collaboration improves patient outcomes and job satisfaction among healthcare workers. Now, there are many global initiatives related to interprofessional collaboration, and most of these stem from the World Health Organization's publication of Framework for Action on Interprofessional Education and Collaborative Practice. The World Health Organization published this document as with the intention of improving a fragmented healthcare system, and they highlighted the need for interprofessional collaboration in those of us who are already practicing, but also the need for interprofessional education, a standardized education for students so that they're prepared to enter a workforce that's highly integrated in interprofessional collaboration. As many of you have probably noticed, interprofessional collaboration is now a requirement of many, if not all, health profession accrediting bodies. So for pharmacy specifically, the ACPE or Accreditation Council for Pharmacy Education included interprofessional collaboration as part of its competencies in 2016. Interprofessionalism is also now included in the core entrustable professional activities or EPAs for new pharmacy graduates. Interprofessional education has historically occurred in like simulations within didactic learning, which is great and is a great mode to introduce interprofessional education early on in the curriculum. However, there is a growing need for interprofessional education to occur within authentic clinical practice settings so that learners can have real life collaborative practice experiences before they enter the workforce. Next slide.
And so to further elaborate on the background that Dr. Aginiga has already provided, I wanted to introduce the Interprofessional Education Collaborative, also known as IPEC, that serves to help support this progress we're making in interprofessional education and practice. So IPEC is a collaborative group that's comprised of 6 national associations of schools of health professions, and pharmacy is included in that collaborative team. It was originally formed to promote and encourage the efforts to advance interprofessional learning experiences, and the anticipated role in which those learning experiences occur is within the didactic setting and also supported through that clinical practice setting as well. To help further align common goals and common competencies in which these learners will engage in interprofessional collaboration, IPEC constructed a list of core competencies in 2011 and further updated them in 2016. And this was ultimately achieved or sought to organize the core competencies within that singular domain of interprofessional collaboration and push the envelope towards achievement of the WHO's objectives. These core competencies have been developed to support achievement of this vision and include values or ethics for interprofessional practice, roles and responsibilities, interprofessional communication, teams, and teamwork. And here at UNT, these are core competencies that we see integrated within the various levels of our training for our learners, both in the didactic session and in the practice session. Next slide. So to further elaborate, these 4 core competencies and their competencies were developed on the principles of being patient-centered, community-oriented, and outcome-driven. They sought to align common, meaningful language for all of our learners across the health professions, have applicability across the learning experiences and curriculum, and be used regardless of the practice setting and team in which that learner may participate. As an interprofessional preceptor, we present this knowledge and help to further support the understanding of the objectives for your interprofessional collaboration that further can support your successful integration, education, and optimal training for that team-based practice that you provide to your learner. Next slide. However, as with anything, we can't not expect some challenges. So deploying these learning experiences that support that achievement of the vision of IPEC, there have been documented challenges within the literature. So ultimately, IPE precepting is not an easy undertaking. And so hopefully today we'll be able to help support you in providing or anticipating challenges that may be faced, and also provide some strategies. And so here I've broken down possible challenges into 3 main buckets. The first being clinical practice setting. The second being the IPEP model that may be integrated within the practice setting itself. And last, what the preceptor themselves may anticipate. So like I said, one of our next speakers will talk with us about strategy to overcome barriers or lessons learned related to facing these barriers. However, the objective I would like to achieve here is the recognition and anticipation of hurdles that the interprofessional preceptor may face. So in particular, you may find within the clinical practice setting that there is a culture of hierarchical relationship among the preceptors and or a lack of interprofessional collaboration. You also may find other typical challenges that we may face as preceptors or clinicians, regardless of our role in precepting, and that can include workload demands, how do we find space for our learners, and then what is that scheduling model in which supports that interprofessional team-based care. Next, you may identify that you may not have a robust IPEP model in place or IPE curriculum that will support your integration of the IPE learner as the IPE preceptor. Lastly, in the role of the individual preceptor, literature has suggested that individuals are very confident in precepting their own professional learners. That makes sense. However, what we've seen in survey data is that there is a low confidence in the preceptor just from the perspective of having the experience, training, and knowledge to be successful in precepting a learner from another healthcare profession. I would argue that each teacher or preceptor has the foundational skills to take to successfully support achievement of the IPEC core competencies in the IPE preceptor role. However, professional or preceptor development is going to be a necessary step. And so I'll transition back over to Dr. Aginaga, who will take us through initial knowledge points and steps for leveraging interprofessional learners' foundational skill sets.
Okay, so it's been identified that the ideal team of interprofessional practice is medical, nursing, pharmacy, social work, and dietetics or nutrition. However, really the best starting point is using the learners that are already there. So this is just an example. At our practice site, we take pharmacy students, DO students, and physician assistant students as well. And so knowing that we have those learners, the first thing we want to do is figure out what are their outcomes, competencies that they need to achieve prior to graduation, where are their overlaps, and where are their differences. So this is just an example of how we mapped within our clinical practice. So looking at pharmacy outcomes, specifically in the middle, you guys are probably familiar with these. These all came from the ACPE standards. Comparing them to the competency domains for medical students and the competencies for physician assistant students. So we've highlighted some similarities, so some notable similarities in foundational knowledge, thinking about clinical sciences, social and behavioral sciences. Additionally, the kind of overarching goal of delivering optimal patient-centered care and developing evidence-based therapeutic plans. And then you'll see some soft skills that also overlap with interprofessional collaboration being highlighted among all three professions. Some key differences that are probably not news to anybody, but that I want to highlight are that, physician assistant and medical students, they're focusing a lot more on diagnostics, physical exam, referrals, and procedures, whereas pharmacy students are not really focusing on those areas. They are focusing more on the medication use system management and using their knowledge of biomedical and pharmaceutical sciences. Next slide, please. So we can use these similarities and differences to figure out how we integrate these different learners into a pharmacy clinic using their unique skill sets, but also using their overlapping skill sets. And honestly, regardless of the similarities or differences, what we want to do is find tasks that are, one, meaningful to the learner, a good learning experience, but that also add value to patient care. So thinking about what can these learners do before a patient visit, in the pre-visit planning, what can they do during the visit, and what can they do after. Where there are similarities in skill sets, students can alternate overlapping responsibilities. So as an example, if a pharmacy student is paired with a medical student on a patient, both of them have patient interview skills, both of them have documentation skills, both of them can check vitals and things. So those things are what the students can work out together and who's going to participate in which parts of the patient interview. Typically, we would have Pharmacy students focus more on the medication aspect, the medical students focusing more on review of systems and physical exam type responsibilities, but with them overlapping, they can alternate these. Where there are similarities in skill sets, this is opportunity for peer-to-peer feedback. Since they have similar competencies, that students may have strengths in certain areas than others. And so this is a great opportunity for the students to give feedback to each other that helps to supplement feedback given by a preceptor. Where there are differences in skill sets, this is where we leverage the students' unique skill sets. So for example, again, having the medical student focus more on like the physical exam, where the pharmacy students may be more aware, but they may not have quite as much mastery of that skill. The differences in skill sets are where we have opportunity for peer-to-peer teaching. So they can teach the other where they have, higher strengths. So the medical students can educate pharmacy students on potentially like diagnostic criteria that would differentiate one pharmacotherapy option over another. A simple example I think of is the diagnostic criteria for cystitis versus pyelonephritis, which could help gauge the antibiotic of choice. On the flip side, pharmacy students can help educate our medical students on proper medication reconciliations to get the information that they need, formulary management. So for example, if the students identify they want to start a GLP-1 receptor agonist, the pharmacy students may have the skill set of looking at the formulary to see what would be covered by a patient's insurance. And the pharmacy students can also educate on things like identification of a drug-related problem. So when a patient comes in with GI-related symptoms, the medical student may be working on their differential diagnosis, and the pharmacy student can educate that if a patient's on a GLP-1 receptor agonist, that could be contributing to the GI-related symptoms. Next slide, please.
And so with that, to round out our process on integrating the interprofessional learners, we want to understand that there's going to be expectation for evaluation and feedback to that learner. And what we've seen in the literature is that there is demonstrated quality to providing that evaluation, and it promotes communication, interprofessional collaboration, and teamwork. And so hopefully, as you've been listening to this presentation today, you can see that we're making progress to link this interprofessional precepting role back to those IPEC core competencies. So fortunately, to achieve that why behind feedback and evaluation, we're able to leverage some of the same best practices for providing an evaluation of the learner from within your own discipline that can go back to the interprofessional learner themselves. So recall that evaluation is formative, it could be summative in nature, and it may be dependent on the IPEP model constructed and can contain components of feedback. Evaluation should be timely, based on established goals and objectives, including those that are overlapping to your own profession, and also assess achievement of the IPEC core competencies. In providing feedback and evaluation, consider the use of various tools and settings. So maybe that includes the start, stop, continue feedback tool. Maybe that includes the sandwich model, various tools in which you already may be familiar with. I would also encourage engaging the interprofessional learner in self-assessment and reflection, and also leverage peer feedback that has been shown to also support growth towards achievement of the core competencies, specifically related to interprofessional communication. And the RISE model, which stands for Reflect, Inquire, Suggest, and Elevate, is an example tool that supports the giving and receiving of meaningful peer feedback that you may be able to engage within your interprofessional precepting model. Next slide. Furthermore, there are validated evaluation tools that are available to support the IPE preceptor in that evaluation process, and they have been developed to align with the IPEC core competencies. The purpose of these evaluation tools are to be used across different health professions, clinical settings, within various teams, and they are not intended to coincide with specific years or levels of learner. So examples of assessment tools that are supported by the National Center for Interprofessional Practice and Education include the Interprofessional Collaborative Assessment Rubric or the Individual Teamwork Observation and Feedback Tool. Furthermore, Nexus offers a gateway publicly and free to various users that also comprise other assessment and evaluation tools that can be evaluated for utilization within your IPEP model. And with that, we are going to close out that brief introduction on IPE precepting and turn it over to our next speaker, Dr. Dang.
Well, thank you so much, Drs. Aginaga and Dr. Westling, for that introduction. And absolutely, it's going to kind of catapult us into our next section with Dr. Dang. So for time's sake, we'll move right on to that. So Dr. Deborah Dang is an associate clinical professor of pharmacy practice with the UConn School of Pharmacy. She is a board certified pharmacy specialist with added certifications in diabetes education. And she practices with the Bergdorf Primary Care Clinic in Hartford, Connecticut, and has a strong interest in innovative interprofessional education and collaboration for research. Her section is entitled, "It Takes a Village, Evolution of Interprofessional Precepting in the Primary Care Setting." Dr. Dang.
Thank you very much. And it's good to be here, everyone. And thank you, Dr. Aginaga and Dr. Westling, for that great overview of considerations that we all should keep in mind when we're engaging in interprofessional precepting. So today, I'm going to be sharing my experiences with you. And if you could go to the next slide, please, on the different type of IPE and IP precepting that I've been involved in over the years, both in the with the P4s and the other learners at my clinic, and also in the pre-APPE years in our interprofessional curriculum that involves 6 different health professions. So I'll be talking about some opportunities, challenges, and my lessons learned. Next, please. So briefly, over the years, I've developed a lot of different IPE initiatives in both the didactic and the clinical setting. Some of the biggest one involve my activities at my primary care clinic, but also with the urban service track curriculum. And if you go to the next slide, there are certainly a lot of challenges and a lot of opportunities that can occur with interprofessional precepting. I think we all can agree that precepting students from another professions or multiple other professions are can be very different than precepting our own students. And you heard in a previous presentation about what some of those challenges might be. Certainly one of the biggest challenge is just the time it takes to really understand your learner's perspective, especially if you're precepting students from 2 or 3 or 5 or 7 different health professions. But also I find that there's a lot of great opportunities again that can come from interprofessional precepting. One of my favorite definitely is just the ability to get to know the students as well as the faculty from the other professions and seeing their perspective, which may give me fresh new ideas about how to better take care of my patients or how to better teach my students in the didactic setting. And at the same time, you know, a great opportunity for me is the ability to teach those set of students and faculty about what pharmacists are all about, you know, what are pharmacy students learning in school and those type of things. So I'll be sharing some of that as we go on through, you know, the next few minutes of my presentation. So to briefly start out with the first part of the first half of my experience, focusing around our curriculum that we have at UConn called the Urban Service Track. And so this is a curriculum that combines 6 different health professions, 4 different campuses, and 2 different universities. So within UConn, we have students and faculty from the School of Medicine, Pharmacy, Dental Medicine, Nursing, and Social Work. We also partner with a private university in our state called Quinnipiac, and they have a very strong physician assistant program. And this curriculum main goal is to teach future healthcare profession students how to best take care of urban and underserved populations and how to do so in an interprofessional team. We also have a 4th goal, which is to encourage students to pursue primary care as a career pathway. So we like to summarize that the whole goal of the urban service track curriculum is urban, underserved, interprofessional, and primary care. In terms of the curriculum itself, if you go to the next slide, just a brief overview of our multifaceted curriculum. We have learning retreats where we teach students how to take care of different vulnerable populations. So for example, we have a learning retreat focusing on care of homeless persons, another one on care of immigrant and refugees populations, one on caring for children and teens living in the urban environment, experiencing toxic stress, another one on LGBTQIA+ communities, and several others. Now, probably the biggest part of our curriculum, though, is the community outreach activities. So in between the learning retreats and the other activities within this urban service track curriculum, we have students go out in the communities and implement health-related education, health screenings, similar types of activities in our urban environments with our vulnerable populations that they've just learned about. And so in total, we run about 60, actually more than 60 community outreach events a year. And every year we actually have added more and more to our roster of outreach activities. And these activities occur throughout the state with a whole range in ages of community members. So anywhere from small children in kindergarten all the way to older adults. The unique thing about our curriculum, if you go to the next slide, is that we have students from 6 different health professions, but at any one time we have up to 13 levels of different learners. So if you look at the hexagon there on the bottom of that page, this is what I mean by 13 educational levels. So this is, by the way, is an add-on curriculum. So the students complete the urban service track curriculum on top of the mainstream curriculum in each of their respective 6 schools. So for example, my students would complete the urban service track curriculum on top of all the other requirements that they are participating in the regular PharmD curriculum. Now, it is a 2+ year curriculum. So at any one time, we have really 2 different cohorts of students. We have students who have just started with us in the urban service track curriculum, and students who have already completed the 1st year and now are going on into their 2nd year of UST. So in the 1st year of the curriculum, we have more entry-level students. We have 1st year medical, dental, PA, and social work students, and then we have P2s and P3s. Once they finish the 1st year, they move on to the 2nd year. And so at the same time, we also have 2nd year medical, dental students, 2nd year social work and PA students, which that is really their last year in those 2 curriculums, so they're quite advanced. And then we have senior students in the BSN program, so nursing students also about to graduate, and then we have P3s and P4s, so that in total, that's 13 different levels of students. That gets a little bit tricky when you're trying to precept students in their community outreach activities. Now, not always, and most of the time, we don't have all 13 levels of students doing one activity at the same time, because there are 60+ different events. You know, we have a whole variety and combination of students each time, but certainly there's a lot of different levels of students that the preceptor have to oversee and train and navigate. So how do we overcome all those differences in educational levels, in curriculum, in experiences? There's a few things that we try to implement every single time that has worked really well for us. So number one, we explain to the students very clearly what's the goal of this outreach activity. So for a health fair, these are our goals. For an interactive Q&A session at a senior center on asthma, on vaccine, these are different goals. When we're interacting with families, with young children, these are a different set of goals. For example, we do an activity called the asthma camp with small kids and their families. That's a completely different set of goals than, let's say, a health fair. So we have clear goals that we explain to all the students at the beginning. We also have clear expectations from them, what are appropriate for you to do and what's not appropriate for you to do. One of the things that students get really excited about is, especially because these are younger students, so their 1st year medical, a P2, a first year social work students, for example, as soon as they learn that therapeutics or that discussion or that communication pearl in the regular curriculum or in the USC curriculum, they get very excited when they go out and, you know, they get to talk to a community member about it. So we try to make sure that we tell them, listen, you know, just because you're providing health information or even doing an oral health screening at a health fair, an oral cancer screening, a foot exam, etc., these you cannot consider the people that you interact with your patients. You don't have a healthcare professional patient relationship with somebody coming into a health fair. You don't know the, you know, most things about them. So just to kind of set those clear expectations as far as interaction, you know, ways to communicate with the different vulnerable populations. One of the most important things that we do to kind of mitigate all the differences in the different levels of skill sets, mainstream curriculum, as far as, you know, social work students, you haven't had the therapeutics of XYZ yet, or D1s, you haven't learned about asthma medication yet, is that we do a primer or essentially a practice session. So this occurs usually about a week or so beforehand, before the actual live event. And basically it's a mock event. So let's say I'm doing a health fair with my students and we are bringing 6 or 7 topics. The week before, we will do a mock health fair and everyone gets together and, you know, run the event just like it was the day of real life. Before the practice session, actually, students get assigned their topics. So if I am running a health fair with 6 or 7 topics, each student only get assigned 2 topics. That way it's a little bit more manageable for them. They still get the variety of topics, but they don't have to learn so many at once. They get the readings or, you know, something brief that explains to them, here's what information you're going to present, here's how to engage the community members. This is not a lecture, you know, this is an interactive discussion with your community members. And then they're told to really learn that topic thoroughly, because at the mock event, the preceptor will walk around and will really try to quiz and trip up the students so that, you know, when it comes time for the real event, you get asked tough question by a community member, or you're asked something that's out of your scope, you know how to handle that situation. Another really important point in our community outreach activities is the utilization of the senior students as team leads or co-leads. So senior students are those in the 2nd year. They have a little bit more experience. They may have done this particular outreach event last year, and it's always an interprofessional team. So at a health fair, I might have 3 or 4 different co-leads, and they're all from different health professions. And the co-leads are really helpful to the preceptor in that they're kind of my eyes and ears, because I can't be in all 7 places at once. But, you know, they can also walk around and support the younger students, listen to what's being said, pull me over to this booth if there's a tough questions or if there's a confusion about something. And then our senior co-leads also are very helpful in terms of teaching, that peer-to-peer teaching with the younger students. So if you go on to the next slide, I'm going to move on now to my IP experience in terms of precepting in my clinic. So in my clinic, I initiate again a number of different type of activity, IPE activities over the years. These are some of the biggest ones, and they're still in place today. So when I first arrived at my clinic, we didn't really have a model of pharmacy students and med students working together closely, doing direct patient care together, where they go into the same room together, examine the patient, do the physical assessment together, do the patient interview, and get precepted together. So we started something called the PharmD MD student team, and it's been in place for many years, really a popular part of the rotation. And then a few years after that, we expanded into creating teams of P4s plus medical residents. So these are medical residents in our primary care residency program at the UConn School of Medicine. And so the P4s will work with mostly PGY2 second-year medical residents, sometimes first-year or third-year medical residents in 3 big clinics, which is our interprofessional A1C clinic, take care of our most uncontrolled patients with diabetes, hospital discharge clinic, which is for our patients who were recently admitted in the discharge from either an acute care setting or a skilled nursing facility, and then pre-op clinic, which is for our patient pending surgeries or a major procedure like a colonoscopy, and the surgeon or the specialist have asked us in primary care to medically clear the patient, saying that all their chronic conditions are stabilized enough so that they would be, it would be safe for them to have surgery or this particular procedure. If you go on to the next slide. So this is just a simple graphic showing the sort of the relationship between the faculty and the learners in these experiences. So, I precept, co-precept with a medical attending, and then we all interact with the P4s, the med students. Med students are in the third year of their curriculum. Sometimes we do also have M1s or M2 join us. And then with medical resident, we mostly have PGY1s and even more so PGY2s. And this graphic is just to kind of demonstrate that it's very much an equal relationship in terms of the co-precepting between myself and the medical faculty. There's not really any kind of concern as far as, who's in charge and who's not in charge. If you go to the next slide. So in terms of P4s working with med students or working with medical resident, you can certainly see that there potentially is a mismatch between their skills, their knowledge base, their patient care experience. Even when med students and pharmacy students work together, right? We know we have two different sets of students, two different set of experiences, two different level of comfort with working with patients or, understanding of diagnosis or medication and things like that. But even more so when we have students, P4s, working with PGY2 medical residents. Certainly when the P4s first come on rotation, they get quite nervous when I say to them, this is the model. I expect you to go into the exam room and to talk to the patient at the same time as the medical resident, who may be much, much more well-versed in that than you, but you're gonna hold your own. You're gonna do the physical exam together with that med student or that medical resident. You're gonna come up with a treatment plan together, and then you're gonna come out and you're gonna get precepted together, and you're gonna have to defend your treatment plan, just as well as the medical resident or the med student. So they certainly get a little bit nervous about that, just because, there is that perception that there's quite a bit of more experience with the PGY2 medical resident compared to the P4s. But I find that this really encouraged them, the P4s, to step up their game. And then I actually do a lot of prep work beforehand with the P4s. So several days before, each student will be assigned patients, and they will thoroughly read the EHR, complete a worksheet I have for them that kind of clearly organize their thoughts. And for each of the recommendations, whether that's med related or not med related, they have to come up with a plan A and a backup plan. For every single recommendation, drug interaction, things like that, they have to tell me the why and the so what. Why is this happening? Why are you making this recommendation? So there's a drug interaction here. What's the mechanism? And so what are we going to do about it? We discussed the day before all of this. So the pharmacy students have a separate session with me where we thoroughly, kind of prep for the next day's set of students, patients. And we discuss all their plans, plan A, plan B, sometimes plan C, and then we practice what if. So what if this patient says, I don't want to do this? What if the medical resident says, oh no, you don't realize I've already done X, Y, Z already. What if the team doesn't take your recommendation? So this inspires a lot of confidence in the P4s, but it also inspires a lot of confidence in terms of the medical residents and the team, because sometimes some of our medical residents have never worked with pharmacists before, or specifically with pharmacy students before. They kind of don't know what to do with them, and they're kind of, okay, why should I have a pharmacy student tag along with me? I know how to take care of a patient. So seeing the P4s so well prepared really kind of changed a lot of people's mind, especially if they've not gotten a lot of direct patient care in the outpatient setting with pharmacists before. And also seeing how the medical attending and I co-precept really gives the both sets of learners, med students, medical resident, and pharmacy students, the idea of how, two different healthcare professionals can work equally, on the same playing field, no kind of power trips from either one of us, and how we can best take care of that patient. One of the things we really try to do, my co-preceptor and I, with our learners, is we role model conflict resolution. So there's plenty of time when I might be more aggressive with the treatment plan than my co-preceptor, and she's more conservative, or vice versa. And because we work together for a number of years, we actually know what each other one's thinking. Why am I being so conservative? Why is she being more aggressive? Why do I recommend A? She says B. But we try very much to articulate our thoughts. We know what the other person is thinking, but we want to make sure we explain that to the students. So, Dr. So-and-so, why do you think this? Why are you recommending this? Why should we get this lab instead of this lab? And, there's plenty of time where we still disagree, and we really try to role model, okay, what's the best way to come up with the answer that we can both accept to our students and our medical residents. The other thing that we do after each clinic session is we do a debrief. So we debrief at the end of the session, students, residents, what's the take-home message after you've seen Mr. A, Mrs. B, Mr. C, etc., in terms of both a therapeutics point of view, and also patient communication and physical exam and diagnosis point of view. So it's kind of, because we have such complex patient population, as I'm sure you all have at your clinic, it sometimes can get very confusing to the students and the medical residents. And especially if they've heard myself and my co-preceptor discuss, 5 different options for that treatment plan, it gets a little bit confusing for them. We always do a debrief at the end. I actually do a debrief at the end with P4 separately too. So then that way, I feel like it gives them a safe place to tell me, well, how do you think that went? Did you enjoy working with XYZ medical resident? Were there any conflicts that I didn't know about, that I didn't see, that was happening in the exam room, and how did you resolve that? Or what could we have said, better next time? Next slide, please. So earlier I showed you the short, simple diagram of how the attendings and the students and residents interact with each other. This is actually the reality. Every preceptor, both myself and my co-preceptor, interact with every single student and resident at the same time. So there's not just clear cut, I only talk to the P4s, and then we listen to what the medical people are saying. We all interact with each other. And if you go to the next slide, it actually gets a little bit more complicated than that, because of course our learners also interact with the other clinical staff in the clinic. So we have a PA that always joins us for all of our team sessions. He doesn't directly precept, but he's there to also provide his input. Our learners interact very directly with our RNs, who are kind of that lifeline between us and the patient. They interact with our APRN in the specialty clinic, with the chief medical resident, who sometimes get involved with the teaching and the precepting as well. And in the years where I've had pharmacy resident, they get very involved with the teaching and the precepting also. And then other clinical staff, such as our social worker, our community health workers, they all get to have an input to our learners. And that's a good thing, because then our learners get even broader perspective. So if you go to the next slide. And then the last model, and this one is just to kind of show, I think of the interaction between all the learners and the preceptor and the other healthcare professionals as kind of more like a web instead of a straight, up and down type of hierarchical arrow relationship. If you go to the next slide. So the last model in our clinic I want to briefly talk about is when I had my own residency program, I had my pharmacy resident work with the chief medical resident. And they actually function more like, almost like attendings, where they would come up with lessons plan. They will come up with didactic therapeutic teaching sessions for the rest of the medical residents in our clinic, which number about 30 or so. And so that model is really well received as well, because the attending and I, again, role model, okay, how do we precept residents? How do we teach them didactically? But then we kind of give carte blanche to the pharmacy resident and the chief medical resident to also come up with their own treatment plan and implement that and get feedback from us. So the last slide is on some of my lessons learned. So lesson learned would be, one, we really, if we're precepting more than just our students, we have to know a little bit about the other types of students, baseline knowledge and their experience. So for me, that's the easiest is just to go directly to the source. What are you learning in school? What have you learned already? What did you do in your previous rotation? Clear expectations. When you go into a room together, pharmacy students, you're not standing in the back just because the medical residents know a lot more than you. You're expected to thoroughly participate as equally as the more advanced PGY2, for example. Obviously, thorough preparations that helps the pharmacy students feel a lot more confident and be well prepared. I also prep the medical residents. So on the first day of their rotation, I give them a syllabus to the interprofessional clinic, and I say, okay, you may be used to these other models. Here's what we do, how we do things in our clinic in terms of the interprofessionalism. Very important for me to partner with other preceptors. That helps me, learn from them, for them to learn from me, but also kind of share the workload, right? I also mentioned already debriefing and role modeling the conflict resolution, because we don't want to tell our students it's all flowers and bird singing when we engage in interprofessionalism. There is a lot of in real life conflict resolution, but how do we get over that? So that's sort of my brief takeaway on what I've learned over the years in terms of interprofessional precepting.
Thank you so much, Dr. Dang. A lot of really good information. I was taking a lot of good notes there. And so we have one final speaker for you this afternoon for just a few minutes. I'm going to turn it over to Dr. Ashley Crow, who is a clinical associate professor and director of interprofessional education with the University of Kansas. She is currently practicing as an ambulatory care specialist at the KU Family Medicine Residency Program, which is at the Via Christi St. Joseph Clinic in Wichita. Dr. Crow, please round us out with your portion on layered interprofessional precepting in a family medicine residency clinic.
All right, and I apologize, maybe I sent the wrong one. I'm actually up in Kansas City now, so I'm at the KU Med Center. I have been at Via Christi though previously, but we can go ahead and jump right in. So I'm just giving the clinic or practice example, and so we call this the Interprofessional Teaching Clinic. It has been going on since about 2011. It started off first with just medical students, but has transitioned to including pharmacy. And then we also have health professional learners from dietetics, occupational therapy, physical therapy, and psychology. So IPTC functions just about every single day. We do half-day sessions Monday, Tuesday, Wednesday, and Friday morning. And then we also have a Wednesday afternoon. Medicine and pharmacy are always present. As you can kind of see in these photos, we have a large conference room. So, I really enjoyed my co-presenters' presentations. I think they fit in nicely with what we are doing at IPTC. So we are lucky that we've been given space. We have 4 dedicated exam rooms so that our teams can go in and see the patients together. So we normally, if you want to go to the next slide, see about 6 to 8 patients per half day, and we have 4 teams running at a time. Now, the makeup of the teams really just depends on what professions are present, but we usually always have 1 medicine and 1 pharmacy student on each team. And the goal is for each team to see at least 2 to 3 patients per that half morning. We really did have to find the right balance of seeing enough patients that the students feel like they're getting a good clinical knowledge base, but also balance out allowing enough time for that interprofessional collaboration to occur. So kind of how we make this happen, if you can go to the next slide. We have the student teams huddle. And again, it depends on the flow of the clinic and what's going on, but we usually try to give them at least 5-10 minutes. And so this gives them a chance to get on the same page, determine how they're going to approach the visit and what needs to be addressed first. Then we allow the teams to meet with the patient for about 15 to 20 minutes. We have been incorporating Microsoft Teams, and this is how we can communicate with the teams to let them know that they're running up on time and need to start wrapping things up. The student team then returns to the large conference room where, again, they'll get a little bit more time to do a post-visit huddle, look up things, come up with a plan, and then we also encourage them to discuss how they're going to present the patient together. And so, as you saw in those photos in the last slide, all of the preceptors are sitting in the same room together. So we're all there present and listening in when they present the patient. Like Deborah mentioned, we try to role model conflict resolution. We try to role model each of us being comfortable enough to ask questions or say we don't know the answer. I think that's been a big thing for our learners. They come in really uncomfortable that first day, not knowing exactly what it's going to look like. And so we just tell them that, you know, our only expectation is that they keep an open mind and put some of their skills into practice. And usually that kind of helps calm their nerves a little bit. But after the team has presented the patient to the preceptors and we've come up with a plan, then the entire team goes back in with the patient to kind of share that plan with them. And then they keep doing this with each patient after that. And so kind of what's been unique to our clinic, and yep, we can skip this one. This was just kind of telling you how we adapted for COVID, but for sake of time, what we did uniquely in the last couple of years was we have included third-year medical residents into the clinic. And so we started this experience, one, so that they could get more intentional interprofessional collaboration, but also two, it's giving them that experience to practice being an attending. And so they really are putting that interprofessional precepting into play as they are going to be the ones leading that entire team. And so these are some of the goals and expectations that we set forth for our residents. We do an orientation with them, kind of do preceptor training as well, teaching them some of the important factors that the first presenters went over that Dr. Schrader and Dr. Zaki had created. And I was fortunate enough that they were actually the ones who created the IPTC. So we have great resources that we can use from them. But it also gives our chance for the residents to get that practice before they go out and care and have to do this on their own. And so that's where we're kind of getting at that layered learning, layered precepting. So we try to let the residents run the show, but then we are there as the faculty to kind of be their support net and help answer any questions or encourage them to make sure they're engaging all the different professions present, because most of the time when they've come into this scenario, they've already worked with medical students. It's the first time usually working with other health professional learners. So they usually have a lot of questions and they are also a little nervous the first time they come and go through this. The medical residents rotate through our clinic longitudinally. So they're there for an entire year and we just get them on their off months. And so it is really fun to see the third-year medical residents teaching and precepting skills really grow and improve throughout the year while they are with us. And so that's kind of how our clinic operates. If there are any questions, we are happy to take them now. One thing I forgot to mention, at the end of clinic every day, we do an intentional debriefing, and ours focuses solely on the teaming aspect. So we really tell them if you have clinical questions, we want you to kind of tuck those away. We'll save those for afterwards, but we found that this really helps to solidify what the teams are taking away working together. And one thing that we started doing this year was we pick like a word or focus of the day for our students to debrief on. And this has really helped to walk away with more meaningful discussions and debriefs. A lot of times the students would sit there and be a little quiet. They didn't really know what to say or what to talk about. And we have tailored those topics around the IPEC competencies, and also if people are familiar with the team steps, tools and skills. So we do a lot of debriefing around those specific topics, and that's just made it more meaningful takeaways. So thank you.
All right, thank you so much to all of our speakers this afternoon. we will entertain any questions that people have at this time. I don't see any in the Q&A chat, so that either means they've been answered already, or our speakers have thoroughly explained everything very well. But at this time, is there anyone that has questions? We've got about 5 minutes. I do have one question specifically for Dr. Dang, because you mentioned the learner retreats, which kind of intrigued me, and a lot of different topics that you all do during those retreats. So can you explain just briefly how those are incorporated throughout the year? Are they doing during class time or separate, or what's kind of the makeup for that?
Sure. Because our urban service track curriculum is an add-on curriculum on top of everything else they're doing in the PharmD, MD, social work, etc. curriculum. One of the biggest challenges we have is just to kind of find a hole in the schedule where everyone can get together for the learning retreat, because we do say you are not allowed to skip, your kinetics PK class to then go to a learning retreat or a community outreach activities, right? So that usually, for at least in our university, it ends up being, and as you can imagine, to kind of juggle 6 different school schedules is a little a bit of a challenge. So we usually end up in like a Friday afternoon. So they're usually every month or every other month. And we try to do them at a site that's central to all 4 campuses, which is, all those campuses are about an hour apart from each other. So we try to find a central location. A lot of time we try to do it in the community itself. So we've done learning retreats at the senior center, for example. So we try not to be too ivory tower about it and just have it up at the UConn campus or whatnot. They're about 3 hours long, actually 4 hours. The last hour is more of the dinner networking hour. So just take a break, you're not learning anything right now. You are just having fun and talk to somebody not from your school, and dinner's on us, that kind of thing. But the first 3 hours are very interactive. So students come in, they think, oh my God, I'm gonna have 3 hours of lectures on, taking care of this population. It's actually a very brief introduction. We have pre-meetings for them or videos to watch and whatnot. And we usually try to bring in clinicians and community partners. There's not a lot of faculty standing up there and say, this is how I would take care of a person who just recently immigrated to the US, that kind of thing. It's the clinicians in the community taking care of these folks. So we might have a social worker and a lawyer who's working with immigrant populations, as well as a clinician who's worked with that population. The part of the learning retreat is that just the Q&A. Please share your experience working with homeless persons that the students get to do. Another part is a case where they, what's our role of a social worker on this case? And then we usually also have a clinical skills. So how do we do a foot exam on a person experiencing homelessness? How do we do depression screening in older adults? That sort of thing. And then, then you go have fun and you have lunch or dinner together. Because that's, I think, is a really important part of IPE too, is just getting to know somebody else outside of your school.
Okay. Thank you. And we did get a couple of questions that came in. We may only have time for one more though. So the first one that came in was how do you manage patient expectations for patients who are new to this type of experience? And then kind of a second part to that question is why am I seeing a med student, pharm student, and then doctor and RPH? Maybe it could be overwhelming for the patient to be seeing all of those people. So essentially the question is, how do you manage patient expectations? And so I guess I can turn it to maybe Dr. Crowell. You may want to start since.
Okay. Yes, I'd be happy to. So we definitely do still run into this, and actually with how our scheduling system works, I will actually say most of the time our patients may not even know that they're being seen in IPTC. We definitely want to try to work around that. We are fortunate that a lot of our patients have been coming to us for years and they understand that it is an academic medical center. So they, anytime someone has their first appointment, we usually put that expectation out there that you're probably going to work with learners at some point. But we also encourage our students when they go into the room to kind of give them the spiel of why they're being seen by a team, how it's going to run. And usually if we can get our teams to start off with that, that kind of answers all the patient's questions and concerns. And we also try to stress too that yes, we think it makes their appointment take longer, but if you really think about if they had to come and meet with each of these professions individually, that would actually take them a lot more time. And with how it's scheduled, it would probably take about that long for them to see just their one physician at the same time. So we really just try to educate them a lot. And most of the time, I would say hardly ever do we have patients who are just really I don't want to see a team. I don't want to do this. So we get pretty fortunate in that aspect. I hope that answers your question, Jared.
Thank you. And I know we're at time. I really want to do one more question. I know people have to hop off, but this is a good question from Leanna Davis in the Q&A. So many of you mentioned that you're working at academic or university affiliated locations, but can you give any advice on how to speak to leadership about supporting formalized IPE training experiences if maybe you're not in one of those settings? So maybe Dr. Aginiga or Dr. Westling can help us with that one.
I can give you perspective on kind of how we've addressed this with our leadership, even though our HSC Health clinic is on the campus at UNT. I will say that we're still very much operating as if we're not affiliated with a university. And what we've done to communicate this interprofessional education and practice model at the family medicine clinic is to tie it back to quality outcomes and what value the learner adds to the team and the experience for the patient. And so I think that there is some evidence that helps support that. We also internally have kind of done PDSA cycles or done small pilots in which we've demonstrated, you know, what do the students offer in that clinical practice role. And that has helped us kind of guide our next steps for our IPEP model. I don't know if anyone else wants to add to that.
I would just say that we do the same thing in our clinic. We are a teaching clinic, but we are a hybrid model where we're very much a community clinic as well. That's hospital based, and so we try to do the same thing that Megan just mentioned, which is frame students' addition to the clinic as a good thing. As far as we do actually, one of the other IP initiative I didn't talk about is we do QI projects with both the med students and medical residents and the pharmacy students. And so we picked a problem every so many weeks and we say, well, we're experiencing a lot of no-shows, we're experiencing prescribing or lack of screening in XYZ disease state, and how do we improve upon that? And that's the QI project of the quarter, for example, for the students. Or we will get the students to help out with kind of, any kind of projects that is educational for them, but it's going to be a win-win for the clinic as well. So our administrators then get excited to have free labor, so to speak, if I'm going to be completely honest about it.
Absolutely. Okay, well, thank you all for chiming in. Thank you for those who were able to join. I know a few have dropped off. I apologize for a little bit of our overtime here, but good questions, good conversation, and good presentation to all of our presenters this afternoon. So thank you so much, and I hope you all have a good rest of your day.
Thank you, Dr. Wallace-Gay.
Bye.